Welcome to the February 2025 Cure JM Town Hall. Tips for detecting and navigating JDM flares, early detection for better results. Our doctors today presenting are Dr. Jessica Turnier. She's a pediatric rheumatologist at CS Mott Children's Hospital and assistant professor at University of Michigan in Ann Arbor, Michigan. Also presenting today, Dr. Sara Sabbagh. She's a pediatric rheumatologist as well, and assistant professor of pediatric rheumatology in the Medical College of Wisconsin in Milwaukee. Doctors, the floor is yours.
All right. Yeah. Thank you for that wonderful introduction. It's really an honor to present for CureJM. This foundation is very near and dear to my heart and has been very formative in my career and my training. So I really appreciate the opportunity to be here. Today, Dr. Turney and I are going to talk about predicting a flare, predictors of flare, what to do when we think our patients are flaring, and maybe some thoughts you might have as families too, when you think your child or your cared one is flaring. So we thought we would start out with some cases, and these are some scenarios or situations that you might be familiar with as families, of things that you could come across in your child that has JDM. So this is an imaginary patient named Susie. She's an 8-year-old with JDM, and maybe she's been having some problems for the last 3 weeks, some more fatigue, maybe daily belly pain, and it's just not her typical, not her usual. Or maybe she's had joint pain after gym class and softball for the last 2 days, and she's really complaining every day when she gets home from school. It's only been 2 days, but it seems to be bothering her a lot. Or maybe she's had this kind of subtle redness on her knuckles, and she says it hurts when she brushes her teeth for the past 2 weeks. Or perhaps she's been tired and her family's noticed that she won't sit on the floor to play. She won't do puzzles anymore on the floor. It's just kind of weird because she usually would sit down with her siblings, and they just haven't noticed her doing that as much. Or lastly, maybe she's just sleeping more and she just doesn't really feel like she wants to play with friends, is kind of withdrawn and just a little atypical for her usual behavior. So I think as a parent, I'm a parent myself, all of these scenarios would trigger a reaction of, I'm worried. Now what? What is this? What's going on with my child? What do we do next? Most of you might decide to call your pediatric rheumatologist, and I think this is a totally appropriate decision in all of these cases. And these are, of course, just scenarios, and maybe your pediatric rheumatologist might say, you should come in for a visit. We should look into this a little bit further. Or maybe they'll say, you know what, it's only been 2 days. Let's give this a little bit more time. So how do we know that JDM is flaring? Well, some of these things are red flags to me. Redness and knuckles on the knuckles, sore gums, being tired and not sitting down on the floor. Those trigger something in my brain that say, I want to see this patient, and I think I want to see them this week. I'm not sure what's going on, but I'm worried that she's flaring. And other things might be more subtle. The belly pain, the kind of disinterest with playing with friends. And I might say, that's not normal. Why don't you come in for a visit? Because we just need more information. This could be a flare, but I'm not really sure until we get more information.
Yeah, and I just wanted to highlight too, I think this is a really challenging topic for physicians. And from a parent standpoint, when should you be worrying? And I think it's really hard because just as a parent, you worry just about your child. And then on top of that, if your child has a chronic illness, there's even more considerations. And so the worry about flare, I would say, is one of the hardest conversations to have when we're considering weaning therapy. Or a lot of times it is a hard conversation to have because we don't have a lot of definitive predictors. And so we're trying to work harder to get some of those. And we'll talk a little bit more about that at the end. But I think, when you come into a visit to your pediatric rheumatologist, I know when I have a patient or a family that's worried, the first thing I say is kind of, we need to figure this out together. And I don't want them to feel alone in having that worry. So having them come in just to be able to go through questions and really look for any signs of flare on exam and pair that with some labs and potentially even imaging. So initially, we just want to ask some more questions. And there are some things that have been associated with kind of development of flare. So certainly illnesses, sometimes particularly some viruses can also increase some proteins in the blood that we see at the time of flare of JDM, and it could be related to that virus or it could be the JDM. Sometimes in certain patients, more exposure to the sun can actually increase inflammation in the skin, and that can increase inflammation in other places in the body, even in sometimes other organ systems like the muscles. So we want to know a little bit more detail too, just about the pain or the activity level, and if, maybe a child, we have a lot of children who are athletes and who do a lot of things, skiing, karate, dance, and maybe they just had a really hard session. It might have been really hard for all the children in the class. But if that is something that kind of goes away quickly and they're able to bounce back the next day pretty quickly, then likely it was more activity related versus related to juvenile dermatomyositis. Another thing, so the skin rashes can be very specific. And even when you have a viral rash, that can look different than a JDM specific rash. And so, specifically, everyone has heard about heliotrope rash, or kind of a reddish purplish rash around the eyes associated with swelling. Also ulceration of the skin in that area too is more specific to the blood vessel, the inflammation around the blood vessels when there is that ulceration, particularly over joints or other extensor surfaces, the elbows, the knees. Sometimes children will also get ulcers in the mucous membranes in the mouth. You can also see this in the GI tract as well. So sometimes you'll see that as the, severe belly pain, or even sometimes blood in the stool. So that's definitely a very serious symptom that we want to evaluate right away. Another thing, we're trying to do is get more detailed pictures of the capillaries at the base of the nail bed. And we have some other equipment we're trying to kind of get at more institutions and have more people taking these detailed pictures, because we really think that changes in these over time might be able to be predictive potentially of flare, but that really hasn't been studied yet to know. And then at your visit too, we'll also evaluate the strength in the muscles, look for any weakness that's different from previously, and particularly in specific muscle groups. So the muscle groups kind of closer to the central core of the body, the proximal muscles in the arms, in the thighs, particularly is what we're looking for and assessing. And there are some functional tests we do, having a child do a sit-up, having them get up off the floor, and seeing how they maneuver and do that, and has that changed, and has their behavior changed with those skills. And that's what I mentioned here with this kind of test for function. And then labs. I will say that we'll talk a lot more about labs. Unfortunately, the kind of standard clinical labs we have where we measure muscle enzymes. You might have heard like creatine kinase, lactate dehydrogenase, aldolase, some muscle enzymes that are also considered a liver enzyme, so AST and ALT. A lot of times in patients with low disease activity that are already on therapy, or in patients that have chronic disease, sometimes these markers are not very good at all, actually. And I've had patients who have a lot of muscle inflammation on MRI and have a lot of active symptoms, and their muscle enzymes can be normal. So we try to get more than one of them at a time to try to be able to get a complete assessment, at the same time knowing that they're not always that good and we can't trust them on their own. And the exam and oftentimes the symptoms are more important in our evaluation. But there are other labs that I think are coming, and that we need to really centralize and streamline a lab to be testing these so we can get results back sooner to our patients. So one thing we always do, when we see children in the office, is we really consider what are other causes of symptoms, really to direct the best plan of care, and to determine if there's a change in therapy need. We really need to know, well, are these symptoms due to the JDM or not? Is the JDM flaring? And sometimes this can be hard, especially if a child is already on therapy for the JDM. So James brought up a really good question when we were kind of talking about putting these slides together, and that, what is a flare? And there's really not a standardized definition, which can make research in this area hard sometimes. So, we really want to know, sometimes patients are off therapy and maybe it's more clear when they're having a flare, but every child can present differently. So if patients already on therapy, can sometimes be hard to tease that out. One of the big things we always want to know is, could this be infection? A lot of children are on immune suppressing medication, so it's very important to rule this out. So there are some common infections. So for instance, a lot of viruses that are, flu, COVID, even some of the GI viruses, they certainly can present with fatigue and muscle weakness, potentially even muscle pain. And sometimes you can even see some transient muscle inflammation after an infection. And so it's really important to kind of consider that. And I think testing for it can be important sometimes, because if you do have an alternate cause or, a reason to ascribe that to, then that is important to know. There are some rare infections too that potentially can impact children who are on immune suppression that we need to consider. The other one is medication side effect. If a child is on medicines, we really like to ask not only about kind of current medications that are prescribed, but also supplements. Some herbal supplements can actually stimulate the immune system. And Dr. Worth at University of Pennsylvania has kind of written about some of these that can flare dermatomyositis skin rash. But steroids can actually cause myopathy or muscle weakness and fatigue. A lot of our medications, including methotrexate, can cause side effects from the stomach. And so it's really important to consider that as well. Injury, and not only just injury, but also just kind of sports-related, activity-related type of aches and pains that all children will sometimes get. Some children can also have just flexibility in their joints. We're all a little more flexible when we're younger, and sometimes that can actually put strain on our joints and can lead to some pain. Another thing is just altered electrolyte levels can certainly lead to fatigue, muscle weakness. And sometimes if you've had like a GI illness or something like that, you can have altered potassium levels, and that can certainly mimic. And then thyroid hormone levels are also always important, I think, with some of the symptoms that we're talking about as well, too. And please stop me at any point, too, if people have questions in between. So some more questions, when considering, again, is this a JDM flare? As I mentioned, I think the hardest part about this is a flare can look different in every child. I have one little boy where it was always a flare of rash kind of near the eyes with ulceration near the eyes. But I have some children where it is really fatigue. That's the first sign of flare. So I think, really the patient-reported symptoms, I think, are critical, and it's really important that we track these more. Monitoring the course of the symptoms. Sometimes, like Dr. Sabbagh had brought up, the joint pain for 2 days, sometimes it is really important to kind of see the course of the symptoms. And again, this is hard. I think, obviously we don't want to monitor for a long time. We want an answer right away, but sometimes we do need to kind of do an initial evaluation. And if labs look good, if the patient's strong, there's no rash, sometimes we do need to consider monitoring for a few days and then considering setting up imaging. I had a boy that we're doing this now. And so another option is to kind of get an MRI of the thighs, and hopefully we'll have other imaging modalities like ultrasound or things that are a little bit faster. But looking for muscle edema, looking for muscle inflammation, that can be really good information to pair with the symptoms. I always tell my patients, just definitely stay connected. Now through a lot of our portals in the hospital, you can send pictures through the portal if things are changing. So I always encourage my families, just update me, let me know, are things changing? Are things improving? What's going on? And then ultimately just having a follow-up, set up. And then considering how is it going to alter therapy? There are times where there is some uncertainty. There's some uncertainty about, is this truly a flare? But if both family, patient, and I have a gut feeling that it is, and there's not more definitive testing we can do, sometimes we will alter therapy, even without having that definitive answer. So I know, I mentioned muscle enzyme tests aren't really that great, and really they're looking at muscle. And there's other areas of the body that JDM can impact: the lungs, the skin, sometimes the GI tract. And so I think it's really important, we're really thinking toward developing markers that are more broadly capturing all the organ systems and the whole picture in JDM, because I think right now we're not getting the full picture with some of our clinically available tests. We're really thinking ahead to that. And one of those is, I know we've talked a lot about the blood vessels, the inflammation on the blood vessels. The blood vessels are circulating throughout the whole body, and they're potentially a better marker that we can look at in the blood. So right now, BWF is kind of pointed out there down at the bottom, but von Willebrand factor antigen level is seen as a marker of blood vessel activation, endothelial cell activation. But it can vary a lot in different patients. And it is only a good marker for some patients, I would say. And so we're trying to find other ones that can indicate blood vessel involvement and have those more readily available for testing. There are other ones that have been coming. So some interferon-related proteins that are being studied by a lot of JDM researchers. So CXCL10 down there, galectin-9. Those are really good markers, and they've been shown to perform better than standard muscle enzymes like creatine kinase. But the problem is they've been studied in a pretty small number of patients in terms of prediction of flares. So we really need to study it in more patients to really know, especially in patients that maybe they have some low-level disease activity. But again, a flare is a much higher level of disease activity. So knowing like the right cutoffs to use and how to interpret the test is so important. You want to be really definitive to be able to say like this is or this isn't. And so some of that is knowing, the right levels and what, is the elevation that would be considered a flare. And so we really need more rigorous tests to kind of study that, to be able to use them clinically. Neopterin is one that is clinically available. It is still a send out, so it takes about a week at our center, for instance. It's a marker of monocyte activation, which is the type of immune cell that we have seen in the tissue with inflammation in JDM. And so that one I've seen to be pretty sensitive to flare. Like it'll be normal in patients, and when they're having a flare, I always see it rise. So that one I honestly think is the best one that I, routinely use as kind of a clinical test on more of a broad level. So I think there are other proteins too that we're thinking about that we recently kind of studied within patients recruited to CARA and at some of our individual centers, kind of markers of disease activity. And we found some that are indicative of oxidative stress that seem to be good markers. And so there are other proteins that we're thinking about that we're trying to work to study. I think the main thing is kind of working with other researchers, working with patients and families to really get these in use as clinical tests. And we need to designate a place to do that. We need to have a center and a lab say, we're going to have this as a clinical test for JDM, and we're going to get these results back quickly and have that be a focus. And then I wanted to mention too, I really think there are more than just lab markers of disease flare. So we can have imaging markers of disease flare. Nail fold capillaroscopy, nail fold video capillaroscopy, I think is really, really great. I know it's been really helpful in our clinic because we can use it right away. We can use it on the first visit with a patient. We can use it diagnostically. We can use it to differentiate patients with JDM from other muscle diseases. We've had some children that were diagnosed with muscular dystrophy, but when we did their exam in clinic, we saw subtle rash, we saw nail fold changes, and that tracked with positive MSAs and an MRI findings consistent with myositis. So this is also something where I think a lot of it's been kind of done, maybe at disease onset. We've seen that it's can be associated with calcinosis if there's severe nail fold capillary changes at diagnosis. Severe nail fold capillary changes at diagnosis also have been associated with chronic disease course. It tends to be if nail folds are more normal at diagnosis, potentially there was less duration of untreated disease. And so we have a lot of studies that kind of look at association with disease activity. But again, we don't have a study looking at flare. And could nail fold capillaroscopy being an imaging biomarker of flare, could it be better than labs? And can it be occurring earlier than symptoms start? And so I think this is something that really, really needs to be studied.
So just echoing what Dr. Turnier is saying, we really need more research to identify early predictors of disease flare before symptoms start. And right now, there is somewhat of a paucity of this in our field. And I think we both are working very hard to rectify this. One thing that's very much needed is standardizing a definition of JDM flare. This means a lot of different things to different kids. There's so much heterogeneity in juvenile dermatomyositis that flares can look a lot of different ways. As shown by our kind of case reports in the beginning, all those kids could be presenting with a flare. And we really need to figure out how we can encompass all these patients together and define what a flare is. We need to ensure that we have adequate data before a flare and during and after a flare. And that really helps us longitudinally assess some of these markers, some of these exam findings, looking at the nail folds to see, could we have predicted this flare? And many of us are already clinically using that, but not in such a way that we are yet experts at predicting flares. It's still a lot of work that needs to be done. We need to be collecting more patient-reported outcome data. Just like Dr. Turnier said, a lot of patients just present with fatigue. That is such a non-specific symptom, and I do not want all of you to go home and think every time my child is tired, they might be flaring, because of course, that's not going to be the case. But we really just don't know what it is that makes that transition over, and what is it about the certain type of fatigue? Are there other symptoms associated? How do we know what's really going on? And are there other lab tests that we could associate with that fatigue and get earlier on that will help us out? And again, like Dr. Turnier said, considering environmental and infectious triggers. Maybe if I have a patient that came in that had a recent sunburn, I might have a lower threshold to see him or her back a little sooner, just to make sure that we didn't trigger a flare. Depending on the patient, everybody's very different. And then, of course, working with patients and families to design research studies. I think the input of our patients and their caregivers is essential in trying to figure out how we predict flare. Nobody knows patients as well as themselves and their families. And so that is an essential piece that we need to input into this research effort. And then lastly, we just wanted to touch back upon what about the worry? I think this is a really big problem in anybody with a chronic disease. Nobody, as I said, knows the patient better than themselves and their families. And so when you feel that something is not right, that they're not behaving their baseline or as they normally do, you're probably right. But then again, there's the burden of having a chronic disease, and that burden is highly associated with anxiety, both in patients and families. And that anxiety can increase our suspicion for flare, and we can think that things that might be somewhat normal in kids might be a flare. And that's incredibly stressful and just leads to a feedback loop of more anxiety. And so in these situations, just having that self-awareness of that worry, of that anxiety, and having a really close relationship with your pediatric rheumatologist is essential. I've had many patients where the anxiety of flare was such a burden on the families that we had phone calls very often to discuss symptoms. We had visits very often, and I really encouraged them to take that burden off of themselves and to put it on me. And if they were worried, just come in for a visit and we'll do a full exam. We'll really look at those nail folds. Maybe we'll get labs if I think we don't want to overpoke kids, but we really need to have a collaborative working relationship so that we're appropriately considering flare, but then also seeking out help when that anxiety and worry creates an undue burden. And I included the resources here that CureJM has regarding that mental and emotional health impact of having a chronic disease, because I cannot emphasize this enough. And I don't think any family is immune to having an impact on their mental health when their child has a chronic disease.
That's so helpful. Dr. Sabbagh, Dr. Turnier, thank you so much for participating in this month's CureJM Town Hall. Coming up next month, it's our Walk Strong kickoff event. Wednesday, March 12th at 8 p.m. Eastern, our town hall will discuss all of the different Walk Strong events that are happening around the country, 20 of those happening around the country, and ways that you can participate in a Walk Strong fundraiser, even if there's not an event near you. You should find registration for that town hall accompanying this video. Also, end of June, it is our flagship family event, the 2025 Family Conference. Space is limited, so register now if you have not already at curejm.org/conference. As noted earlier in this session, here's a great set of resources for you navigating the mental health issues associated with carrying a rare disease like this. You'll find them all at curejm.org/mental-health-resources. And a special thank you to our sponsors as well. And as always, thank you for joining us for another CureJM Town Hall.